so forth, but bring in tort reform. Why have we not heard anything about tort reform being introduced into any medical program? Why isn't it there?
Okay, well, one reason why it's not there is a very strong lobby against it, okay? Just as there's a very strong insurance lobby in this country, the Trial Lawyers Association, just to ask Mr. Weiner, is a very powerful entity and group. But I think there are other reasons why malpractice reform, frankly, hasn't been totally addressed. Number one, it isn't that great a contributor, frankly, to healthcare costs. When you look at it, the actual cost of malpractice, even when people put in defensive medicine, is probably no more than 3% of the total healthcare costs. And finally, let me just say that single payer, we think, would address the malpractice crisis, at least in the short term. Why is that? Because, in fact, 50 to 60% of malpractice payouts to patients has to do with medical care, has to do with the inadequacy, frankly, of private health insurance to cover them when they get a malpractice claim. And under single payer, if in fact all health care is essentially paid for, one could right away reduce malpractice premiums by 50%. So I think there are whole sets of reasons why this hasn't been addressed, but that frankly this reform, a Medicare for all kind of reform, would at least be a nice first step in that direction. We will take more questions. We're not going to evaporate or go away. But why don't we have Representative Weiner come up at this point and address you on what's happening in Congress. Thank you for joining us.
Thank you very much to the panel. Forgive me for being a little bit late. You've already heard a great presentation on what I think is the way to solve this problem. I think that the more we advance in this discussion, the more profound it becomes clear that we've had an experiment between two systems for 44 years. One is about 47, almost 50% of all the dollars we spend for health care in this country right now go to basically a single-payer program, or Medicare, or Medicaid, or VA, Department of Defense, the Bureau of Indian Affairs. Of the $2.7 trillion we're going to spend this year, which, by the way, is about 3 times per capita more than the next closest country. We have good health care in this country. It ain't 3 times better than anyone else. But we've had that experiment going on, and then on the other side, we have this private insurance model, which is basically to try to commoditize something that inherently is not a commodity. In order for it to be a true commodity, you have to have some element of choice that consumers have. And as I've used as an example before, you know, if I fall down here with a ruptured appendix, whatever choice I have kind of goes out the window. I'm not going to say, oh, I'll get an appendix, I go on sale in February, I'll wait till then to do it. Or, you know, I understand that livers are cheap right now, let me get a liver instead of an appendix. Or, you know, I want a blue one rather than a green one. I have no choice except to get the care right at that moment. And since the health insurance company that most Americans have are chosen for them by their employer, they don't have a lot of choices about that either. So we have that model operating, and that model hasn't worked terribly well for either people in it, because we're seeing that insurance companies, almost by their model, are trying to provide as little care as possible, spend out as little as possible, take in as much as possible. And it certainly hasn't been working for us as taxpayers, because let's remember something, you're paying the employer portion of every federal employee, every state employee, every city employee, and all of the retirees. And so not only are those costs going up, not only is the care not particularly good in a lot of cases, but you're paying an enormous amount for it. How much? You're paying about $6 billion just for the uninsured in New York City, just in your taxes. That's just the uninsured, not even counting the employees who you employ. So we have the two experiments going on, and I think that if you looked at it through that lens, and if the President would have started this discussion by saying, hey, let's take a look at how we got Medicare. Let's take a look at the conversation that we had 44 years ago. And let's take a look at what's been successful and what's not, and let's look at the alternatives. And if we would have started at that place, and the argument I had with the president was memorialized in New York Magazine. He concluded the discussion by saying, enjoy your last trip on Air Force One, because we were talking about Air Force One. If we would have started there, we would have accomplished a couple of things. One, we as Democrats, I know you're people of different parties, but we as Democrats would have reminded people that if you want to fix health care in this country, only one party's ever done it, and that's us. And that when we did it, we created something that has been a real success story. If you look at the place that those over 65 were 44 years ago compared to where they are today, they not only didn't have a lot of care, we've elevated we've reduced the poverty rate among seniors. We've created a program that every year we do a survey. 96%, this might have been pointed out, 96% give it, they approve of it. And even the providers, the ones who say, oh, we can't choke the providers off, they put it on a 6-point scale, 4.5. The doctors, the hospitals have given it. This is a successful program. But we would have done something else. We would have asked people whether that program, with its 1.05% overhead, seems like a better value than they're getting from their insurance company, which an overhead and profits in the neighborhood of 15 to 30%. But we didn't do that. The president gave a speech that said a crucial thing that screwed us up. He said that everyone who has their insurance now is going to be able to keep it. When he should have said, we're going to give anyone who has a private insurance policy now something better and less expensive. That's what we should have said. But once the die was cast, that the president then stands up before Congress, and this is how our argument began because I criticized him for this, says some people want a single-payer plan like they have in Canada. You know, the derisive language, like, I'm not sure it's so terrible, but the derisive language that was used, essentially using the language of our opponents. I think we began down a path that has been twisted and contorted. We tied ourselves into rhetorical knots. Well, last week, we came nearly a full circle. That now the same people who have been critical of our compromise, which is a public option, essentially a little mini single-payer plan, kinda, have now come back and said, oh no, we can't tolerate any new government program. Why don't we just expand Medicare? The same blockheads, this is off the record, the same guys who were saying, I can't have public option, are now saying, okay to expanding Medicare from 65 to 55. Now, it ain't that easy. Because while that plan, look, if I were the President of the United States, and you have no reason to fear that will ever happen, but if I were President, I would have said, look, let's take something people know. You know Medicare, you're either on it, you have a friend or relative that's on it. Go up to a 56-year-old guy or a woman and say, how would you like Medicare this year? Watch their eyes light up because of the headache that they have with it. So expanding Medicare incrementally as a way to getting to my ideal of a single-payer system that is really more than just Medicare, because I think there's problems in Medicare. There's no long-term care, there's no catastrophic care. The drug coverage is still a private, weird, outside the system thing. We have to improve Medicare. But if we started doing that, we would not be having conversations about 2,000-page bills here and something else, and this is something that doesn't get widely reported. If you take an existing program and expand it like that, going to this process of reconciliation is very easy because you're not creating a new legislation, all you're doing is changing an existing one. If we would have done that, we would have been in a much better place. Now, we didn't do that. So where are we right this second? We're in a weird place. We're in a place that if they are going to go in the direction of expanding Medicare, that is a very important and I think dramatic improvement from even the public option. Now, and I'll tell you for a couple of reasons. One, it gets us once again thinking about the foundation of this whole discussion again. Because now people have to say, expanding Medicare, I understand Medicare, where did Medicare come from, how does it work, I get it, all right, I understand you want to grow it. And it makes it much easier for us to say, Why 55? Why not 54? Why not 44, 34? Why not take those young people 21 through 26 for who don't want to get insurance, so-called invincibles, and get them invested in the program as a lifelong thing, get them started. So I see it as a dramatically important, although accidental, success of the negotiations. But it's far too easy to say that because we now have them tying themselves in knots about how you buy in to Medicare. Remember, the proposal is not just to give it to them, it's to say, maybe there's some people in this room, anyone between 55 and 64 in the room? Okay, wow, it's a good group for this discussion. It would say, well, let's let them buy in, and then theoretically we're going to provide subsidies to those people as well. Essentially, it'll be another very well-developed public option for that group of people. And they're getting themselves all tied up in knot about how you do it, how you make it affordable, and the like. And then we also have a problem that while I'm out there saying to my progressive friends this is a good thing, they're quoting, Mitch McConnell said on Face the Nation this morning, some congressman from New York said, it's even more derisive than being named Weiner. That's like the worst insult to Mitch McConnell. It's like, wow, really get him. So they're trying to cobble this together, but it's still very complicated. You know what we're learning? We're learning something that's intuitive, and that is that healthcare people look at through the lens of their own experience. And so it's very easy to scare them. It's very easy to scare people, and at the foundation of this whole discussion has been an organized effort to lie to people and scare them. And also to make that, like, their health insurance company, like something they want to protect. There's so many of my colleagues come in these debates with me and say, well, we've got to make sure people can still call their insurance. No one likes their insurance. They like their doctor. No one wants that 800 number on their speed dial just to call and chat with a clerk in St. Paul somewhere. They like their doctor. And so long as we explain to people what we're saying is rather than take your money, give it to the insurance company who then gives it to your doctor, just give it to the doctor. Take all of that money and put it back towards health care, and you'll find a lot of savings. So where do we stand at this moment in these discussions? Well, the Senate's tied into this knot between a lot of competing currents, is understandable. The President has been, and my President, and I want him to be a success, has been derelict in how off to the side of this discussion he has been. I have never seen a big national debate. I've been in Congress 11 years and been aware of stuff before then. A big national debate that if you stop someone on the street and says, what does the President believe about the public option? What does he believe about Stupak? What does he believe about these things? You have a tough time explaining it. That's a problem. Because it's hard to pass legislation if you had the President, visualize this, going to the state of Nebraska and giving a talk about how expensive insurance is in Nebraska and how few choices there are, and how if we do this right, they'll have one other choice and be able to enroll in Medicare, no matter how old you are. And then Ben Nelson goes back to Congress. Don't you think he will suddenly be thinking, okay, now someone's making this case in Nebraska, I better at least be able to explain why the President's wrong. My view is if we don't fix the Stupak Amendment, which you might have talked about already, which essentially would be, I believe, the biggest setback for a woman's right to choose any time in the last 40 years. If we don't change that, if we don't have either the public option or a public plan for people to buy into or at least have available, and the third thing that we need to have, if they come back with a plan that taxes insurance policies that disproportionately hit high-cost areas like New York. That's how they fund their bill in the Senate, because we ain't, like the rest of the world, our health care plans are more expensive because health care is more expensive in New York. If they have those three things in place, we are at that tipping point where they're doing more harm than good. But one way or another, and I'll conclude with this because I've already taken too much time, one way or another, we've missed a big opportunity. And I would say to you this, the notion that getting anything up on the board is better than nothing might not be right, and I'll explain why. This is going to be a legacy moment. We're either going to build on this in years to come to get to our single-payer ideals, or it's going to be a failure, and the American people aren't going to trust us to do it again for quite some time. okay? If you do a bill that's so weak that Americans don't see that their care coverage is getting better, that the cost keeps going up, that the taxpayer keeps getting squeezed more and more, the notion that we won 220 to 209, whatever it is, will be lost in the dustbin of history. And what people remember is, I remember 2009, that's when they had all these big plans that turned out to be crap and the insurance companies made out like bandits. And we're not going to be able to build them. If we come out with something that says, you know, another 10 years worth of people had an experience with a program that was a success, and now 45-year-olds are organizing saying, sign us up too, or that those people in that group say, wait a minute, there's someone 64 who's paying something different and I'm 62, or 66 and I'm 62, why is that? And Congress has to say, well, okay, you're right, this really isn't fair. I think that we are going in a direction that we want, as however imperfect as it might be. But I think that we need to have a couple of elements included, and right now the Senate is teetering on this line of getting it so wrong that it won't be worth doing. But let me conclude this final comment. You know, we as progressives have a fidelity to process and progress that our opponents don't have. Like, we're kind of going into this thing with a gun to our own head, saying, if you're not careful, we're going to vote no, and like the opponents are like, great, who are you threatening? You know, you think Joe Lieberman gives a church here, whatever. You think he cares?
We've already used pissed off.
Yeah. Yeah, well, I'm taking the Brooklyn next step, I guess. So it's a very complicated legislative thing, because you know, you're negotiating with people who at the end of the day would be perfectly happy to keep on feeding the insurance piece. They'd be perfectly happy to do it. So at the end of the day, we're stuck with this difficult negotiating. I couldn't do Harry Reid's job, but I can tell you that we are at a point that all of us have to take a step back. If these various elements fall by the wayside, it might not be worth doing anything else. So that's kind of a status quo. I'm glad to get any questions.
So one of them is the 90% medical loss
ratio.
maximum, the 90% ratio that's the private health insurance firms would have to spend 90% of their premium income on actual medical care,
right,
which reduces the administrative and profit.
Right. Actually, that is, it's something called medical loss ratio. It's funny how they call giving people care medical losses. It gives you an idea how insurance companies look at the world. Oh, we had to make someone better. That's a medical loss. No, it's a good thing. That someone's better. That is only going. We have a number of 85% in the House bill, but it only impacts non-profit insurance companies. Theoretically, non-profit. We've had the growth of these non-profit. Blue Cross Blue Shield is theoretically a non-profit, but frankly, they're not acting that way. They're giving huge bonuses to their employees, to their brass. They're acting essentially like a big corporation. So what we said is, if you want to retain your non-profit status, you have to give out in care a minimal amount of what you take in. 85% is the number in the House. They're trying to do 85. I think 90 in the Senate. I think we're going to wind up having those numbers stick, although they're fighting pretty hard. And by the way, to give you a sense, 85% is for all these nonprofits don't pay a tax rate. That's normal for corporations, so they have very little taxes. That's just overhead. And Medicare, the last actuary's report for 2009 is going to show 1.05% overhead. And because their director makes $170,000 a year, they're fully automated, and the deal that we make with doctors is, look, you're not going to live high on the hog, you're not going to get blowout wealthy, but you're not going to have headaches, we're going to reimburse you quickly, etc. So I think those elements will be in there.
But that's only for, I misunderstood that. I thought it was for private plans.
No, it's only for the non-profits.
Okay.
The other piece very quickly is what is the likely impact of having 55 to 64-year-olds into Medicaid, Medicare rather, in terms of the longevity of the financing of Medicare, which is in huge jeopardy.
Good question. Look, here's something that we need to acknowledge, is that Medicare has a financing problem, but frankly, all health care has a finance problem. You see it less with Oxford because Oxford costs go up $1,000, they charge you $1,050 and they walk away. You know, it's basically, you don't see it as a financing cliff because they look at their model differently. They don't care how much the costs go up because they know they can put a big on each year. And frankly, the 17,000 Americans that lose their care each and every year, well, the insurance companies really don't mind that much about that because they're more likely, frankly, to be not the kind of customers that they want anyway, those that are on that borderline of having a job or not having a job. There's no doubt about it. Medicare, as it exists today, needs help. We need to reimburse something more, preventive care, reimburse some things less. We need to reform the system in a lot of ways. And I think, frankly, that we have to acknowledge it, but you have to look at it compared to what? The private insurance is actually growing at a faster rate than Medicare, despite the fact that Medicare has the oldest customers. And the private insurance companies' rates are going up faster, despite the fact they're dumping their most expensive customers, meaning anyone with a pre-existing condition or anyone that comes to them with too many bills. But you're right. Medicare, we do need to deal with the fraud that exists there, although it's not as high as been reported. It exists, and any dime in a program that's going to fraud, we have to weed out. And I have a piece of legislation, ironically, with Charles Grassley, a Republican, that says that if we have, that it makes common sense, that if someone is submitting too many bills in a short period of time, you slow down that quick reimbursement, it gets flagged, and we make sure everything's kosher before we fire it out. We can't let the speedy reimbursement rate be an invitation to fraud. But there's no doubt about it. If we're going to, and by the way, the Medicare's cliff is in part a credit to its success. Everyone says, you know, you listen to the Fox News report, oh, it's estimated to be 17 billion, now it's 300 billion. Yeah, people are living 10 years longer on average when the program was created. They're healthier, there are more of us. And so to some degree, the fact that people are living longer is a testament to the fact that they're healthier, and that's not a terrible thing. And we just have to figure it out. We have to figure out generally how we deal with the debt shortage in this country. I mean, I didn't coin that phrase. There was an essay in the Atlantic that talked about the coming debt shortage, that we're all going to be living so long, and how we go ahead and deal with it.
Yes, back there. That's you. In the red hair.
Oh, the red hair. I pursue this question about Medicare. Because when half of the financing for this health reform is coming out of Medicare savings, it just seems to me to be that's alone a reason to say, wait a minute, what's going on here? I would like to open it up to, in addition to kind of leave it to the other people.
Yeah, well, here's the way the fund, look, first of all, at 10%, basically, is what we're saying we're going to save in Medicare. $500 billion or so over the course of 10 years, it's basically about a 10% saving. We have to do things that get us savings in Medicare for the reason the gentlelady asked, and also because there are things that we should be doing to reduce our costs. For example, we will reimburse for a hospital down the street if someone breaks their hip, which is about 30% of all admissions for seniors, are slips and falls. If someone breaks their hip, we will pay about $1,100, sometimes even more, a night to stay in a hospital. We will reimburse the Met Council for Jewish Poverty $0 to go into a senior's home and put a rail by their shower. Nothing. We will do nothing to talk to a senior when they're 65 years old about some of their end-of-life decisions they may have to make, despite the fact that 20% of all the expenditures in the entire system are end-of-life. And all these people talk about tort reform, about a third of all the lawsuits are at that very end of life when family members are saying, hey, I read some article about this miracle drug, you didn't give it, I'm suing the hospital because you didn't use it on Aunt Mary. So those types of little basic things that kind of modernize the system some, I believe we can save money.
But don't you think that money should be put back into Medicare?
It is.
Rather than...
No, it is. Well, it's going back into health care. I don't think it's going into the health care. First of all, none of the money is actually coming out. What we're talking about is a growth rate of Medicare to a growth rate of Medicare. That's what we're talking about. It's not as if we're like taking money out of Medicare and throwing it away. We are trying to create a system here in this country. And I think it's helpful for us to think about this, particularly in the context of a single payer system. It should be a continuum. We have this weird, well, which piece of the puzzle? I'm poor, so I get Medicaid. So I get lower reimbursement rates than Medicare, therefore poorer care, but I get long-term care. That's the weird. If you're poor, you get long-term care, you get nursing home care. I'm 65, middle-class guy in Brooklyn like my dad, but he doesn't get any long-term care, but his doctors are reimbursed more highly, so he gets a little bit better care. Or I'm lucky enough to work for a shoe store on the west side of Lexington Avenue, where my boss gives me insurance, but if I work in a pizzeria on the west side of Lexington Avenue, I have no insurance. Tough on me. We shouldn't think like this. It should be that Americans get health coverage, health insurance, and health care because it's cheaper for us to do it that way. It's more humane to do it that way. It makes us a smarter economy. Why the heck should a shoe store on two sides of Lexington Avenue be competing based on what benefits they give to their workers for health care? They should be based on the shoes they're selling. And when you have a problem that you're making a car in Michigan, same company, same union contract, and a car in Toronto on the other side of the border, same union contract, same car, that it makes more sense for GM to build it in Canada because it costs $7 more an hour for health care. How is that smart? So I just dispute the notion that it's taking from here and putting to here. What we're really doing is trying as best we can in the context of this bifurcated system to make a system that largely pays for itself, that with the $2.7 trillion we have, we provide health care for everyone. That's basically the philosophy.
I would just like to add one comment to the Congressman's remarks, and that is, I think the questioner raises an important point, and that is that the perception out there is that money is going to be taken out of Medicare and given to the rest of this proposal, which is largely private health insurance company based. If that were really the basis of this so-called reform, then one would be, to coin a phrase, equally pissed off about that. I think that is very worrisome and really needs to be addressed.
All the way in the back.
Tremendous. Could you just briefly talk about the politics and the law regarding mandates? We have the commodification of healthcare, the absence of choice. Now the federal government employing mandates. The federal government is taking what appears to be an unprecedented step. It seems to, on the right and on the left, people are upset about the mandates. This seems to be a problem and it may even raise constitutional questions in terms of fundamental fairness. What is your thinking about that?
Yeah, well, there's no constitutional...
I'm sorry, I have to interject, and you can all hate me. This actually has to come to an end in the next 5 minutes. My apologies.
Okay, so I'll for the person's benefit, it's for my benefit. Your right not to have insurance only extends to my right not to pay for your health care when you get hit by a car. Not you personally, but when someone gets hit by a car. So, since we are interrelated in that way, that someone who doesn't have health insurance has it paid for by society, the same way we require people to get car insurance, we require people to get health care, I don't think there's a constitutional issue. I can tell you the equity of it. The equity of it is that we don't have some people getting health care and others don't. Everyone gets health care. The only question is who pays and how we pay. And I believe that right now it's terribly inefficient to say that if someone who's uninsured falls down with that appendicitis attack, gets taken to a neighborhood hospital, about 2/3 of the bill gets passed along to us, the other third gets eaten by the hospital. That's not a fair thing to do. So there is some element of personal choice, but in this case, the personal choice of the person impacts society around them, and everyone has to be involved in this. We have an obligation to one another, and it extends to things all the time. Frankly, even if you're all alone in your car, you have to have your seatbelt on, because if you have a car accident, even if it's a one-person accident, we pay for your health care.
So we'll take 2 more questions. You've been struggling right over there. Yes.
I'll try to be quick.
Mr. Weiner, thank you for bringing some sanity to an insane political system. I really appreciate it. I wanted to ask you, there seems to be such a major focus on health insurance. What about the incredible cost of drugs, the drug companies? What about the ridiculous prices for hospital care. I mean, you know, that's the end. That's where a lot of the costs seem to be going. I see what I pay for this stuff. It's totally incredible.
Yeah. Well, look, let me just say this. First of all, there's a very interesting debate going on now that you should be watching because it's fascinating. There's a debate going on in the Senate about whether or not to allow drugs to be imported from Canada. What's interesting about this is not just the issue, which is interesting. We pay for the research, we pay for the FDA. They have a national system, they have cheaper drugs. But there are senators who have this fidelity to this deal that the White House has made to limit the amount of savings we get from drug companies. And I don't understand who wrote that down, but that's what's going on. Look, healthcare is expensive for a lot of reasons. Some of them technology, some of them the lack of a standardized system. If we had a single payer system, that we would have then a single control to make sure people weren't getting 5 or 6 tests over and over again, to make sure we had standards that were elevated. You'd have fewer malpractice cases, not for the reasons that was mentioned earlier, just because we would have higher standards everywhere, and we'd make sure that people would stick to it. But healthcare is expensive. We have to come to grips with that. Even in the best case scenario, a single payer plan is not going to be cheap either. Taking care of people is expensive as we grow older, as we want technology to be developed. We want that person, that brilliant person, to come up with a cure for a disease that only has 10,000 people each year that get it. These things are expensive, but we're already paying, is the point. It's not that we're not paying the money. $2.7 trillion in a country of 300 or so million people is a lot of money.
Let me just take the last question myself. Is there anything that we can do, Congressman Weiner, and also our panel, at this point? What would you suggest that people in this audience do?
Okay, here's what I would say to do. First of all, we've all been through a transition. I'm speaking for people who are in favor of single payer. We started out with our ask. We arrived at this compromise for a strong public option. Let's not lose sight of the fact that the public option was our compromise. Like, I don't want anyone to think, oh, that was our ask, so anything now is our compromise. No, the public option was our compromise. I think, speaking for the people on the panel at least, we're not prepared to say, oh, well, the public option, that was a pipe dream. No, our real dream was single payer. Now, if what emerges out of this, for whether reasons sinister or accidental or benevolent, is that there is some nominal growth in the single payer system, let's at least have an open mind to take a hard look at it. Sometimes, a broken clock is right twice a day. Joe Lieberman maybe got one right. So let's be careful. Let's be careful to leave my colleagues, Carolyn Maloney, Jerry Nadler on the west side, Charlie Rangel. Oh, Charlie Rangel actually might be here. Charlie Rangel just to the north. Let's make sure that we know that our progressive friends in Congress know we're not in love with a slogan. We just want the outcome to be what we want. And on the other side also, we have to make it very clear that there are some things that we consider pretty important at the end of the day here. And that is, there have to be some savings. The insurance companies have to take a haircut. And if we're going to give them 30 million new customers, the very least they can give us is some competition and some choice. Thank you very much.